Last speak for the night. My name's Armand Borovik. I'm a cornea, cataract and refractive specialist, and I practice at all three of our sites as well as at Prince of Wales and Sydney Eye Hospital. So I'm going to be talking about cataract surgery and searching for the perfect presbyopia correcting IOL. It's a provocative title because I don't know if there is such a thing. So what do patients really want out of their cataract surgery? All of our patients get this questionnaire, and the writing's a bit small, but I'll just highlight the central blue box there. And it basically asks the patient, which distances would you like to be free from glasses? And of course, everyone would like to be free from glasses in all circumstances, but a large number of patients circle like this. And you'll see that they say they don't mind wearing glasses in the near zone, but most people don't want to wear glasses for intermediate, so that's really computer and phone, and for distance. And our worlds are really intermediate and distance now, and putting on a pair of reading glasses isn't the worst thing for most people. So what's the problem with our current presbyopia correcting solutions? Well, I always say that if there's a lot of different solutions, none of them really work that well. So monovision, that's fine in the right patient, but you get impaired depth perception and you don't get a full range of vision. So between your near point and your distance point, often people will complain of blur. Multifocals, they work in the right patient, but they split light. So there's often a degradation in visual quality because of that. They always cause glare and halos, and some patients complain of waxy vision for no reason whatsoever. And it's not suitable in eyes with pathology. So traditionally, anyone with any sort of ocular comorbidity has been excluded from a multifocal lens. So is there a better solution? Well, in July of last year, Alcon asked me if I wanted to be part of their pre-launch of a new lens they were introducing to the market called the Vivity lens, which a lot of you have probably heard of by now. This is a picture of the lens up on the right. And you can see that there's a central, I call it the nubbin, which is not the official term, but there's a central donut there, which you can see if you look carefully under the microscope, particularly when the eye is retroilluminated. So what was going to make me change what I was doing, which was working pretty well? I thought, well, let's think about what the ideal IOL would be for me. And I thought it's a lens that can be used in all patients, not just those with pristine eyes, simulates natural vision and takes away the need to have the lens conversation. So patients who want a premium lens, it takes a lot of chair time to talk them through all the side effects, which is very important because they need to know that they will definitely get glare and halos with a multifocal. So this is a new way of trying to give a patient intermediate vision, really. So I'll just go through it in a simple fashion. So basically you can see that this is the lens in profile, and there's this part here, which is the nubbin. And the way I think about it is that increased depth of the lens means that light travels through that part of the lens for a longer period of time, and it bends the wavefront. So it's a wavefront shaping technology. And that way the patients get a good spread of vision, but it's mainly for distance and intermediate. For really close up vision, it's not intended for that. So I looked at my data from the first 80 eyes that I put this lens into. I put it into over 100 eyes now. And when Alcon first described the lens, they said definitely put it into patients who've got normal eyes for the first 10 cases. And I thought, well, 10 normal eyes in my practice is going to take about a year to generate. So I decided let's really test the lens and put it through its paces. So I put it into all comers. And if their biometry suits the lens, I'll talk about that in a minute. So both eyes or one eye with a monofocal in the other eye. And I put it into all sorts of patients. So patients with corneal pathologies like Fuchs, combined with corneal grafts, corneal scars, LASIK, dry eye patients, patients with retinal disease, glaucoma patients with field loss, and keratoconic patients. So what were the outcomes? Well, our refractive target was pretty close to what we were aiming for. The mean was just a bit minus 0.26. But if you look at the post-operative prediction error, that means that are we close to what we actually aim for? We're pretty close. And then the mean distance vision was 7.5 in these patients. That's slanted by the eyes with pathology. And the mean monocular near visual acuity at intermediate distance is N10. So again, this is just showing the postoperative predictive error. So you can see that the graph is just slightly slanted towards minus. When the lens first came out, there was some challenges with the A constant that the lens had attached to it. So that means that when we choose a lens, the company has looked at the optics and they say that this is the power that you require based on that patient's measurements. But they were actually just out, so we were getting some slightly myopic results. So the near vision was pretty good. So N5 in some patients to N10 in normal eyes. I can't tell you exactly what the magic formula is. Some patients just see better for near with this lens, even with emmetropia. The range in eyes with pathology was still pretty good, N5 to N36, and that's in a patient who'd had a corneal procedure at the same time. So just a few quick cases. A 53-year-old man who came to see me for a refractive lens exchange or for presbyopia correction. He was a very keen tennis player. On our questionnaire, he circled that he was low stress and not a type A personality, but I can guarantee you that he wasn't. He was a very anxious sort of guy, and he doesn't want reading glasses anymore. Low hyperope, 6'5", 6'5". So this is one of the most difficult patients to treat because he just wanted more independence from his reading glasses. So incidentally, we found that he had narrow angles. So instead of doing a refractive corneal procedure, we did refractive lens exchange, and he wouldn't have done well with the glare from multifocals. So I suggested we put in Vivides, and I put in a lens aiming for emmetropia on the right and -0.5 on the left, trying to give him that full range of vision. So 1 week post his second surgery, he's 6'6" N4, and I was pretty happy. But he was miserable. He said that I've ruined his life. He can't see anything. I thought, well, what is actually going on here? Is it the lens? Has he got a degradation in his visual quality? So we put up -0.5 in a trial frame in his left eye, and he was very happy. So it turns out he was left eye dominant, which we check in all of our patients, but he was co-dominant, but preferred his left eye, even though he was right-handed. And I did left LASIK on him. This is actually the lowest amount of correction I've ever treated, and he was adamant that he wanted something done. And fortunately, he's 6'6" N4, so that's actually the same vision as he had before his laser, but that's his left eye now, his dominant eye, which is seeing well for distance, so he's happy. Case 2 was another youngish patient who had posterior polar cataracts, so congenital cataracts. Her vision had been deteriorating for a number of years, and I saw her in June of last year, and her vision wasn't too bad. And after a lot of discussion around the risks related to posterior polar cataract, so there's a high risk of the capsule being involved and having a loss of part of the lens into the back of the eye and needing a vitrectomy or putting a lens into the anterior chamber, she decided not to go ahead. And she ended up coming back later on, 9 months later, and her vision was deteriorating further. So she had also developed some posterior subcapsular cataract. So we went ahead with her surgery, and fortunately all went well. And she had bilateral non-toric Vivides and ended up seeing well for distance and for near in both eyes independently. So that's an abnormal cataract, but normal eye, so a healthy eye. What about eyes with coexisting pathology? So another patient who had seen a number of ophthalmologists who had recommended combined cataract surgery with a corneal transplant because she had quite significant Fuchs, but she was petrified of having a transplant. So we decided to do a cataract operation combined with a DWEC. So that's where I strip the central part of the endothelium, but don't replace it with a graft, and rely on the patient's peripheral endothelial cells to spread and fill in the gap which is created. So after her first eye, it doesn't project all that well, but with the eye of faith, the arrow is outlining the Desmais defect, which I've created, and her cornea looks pretty clear there. So 8 weeks post-op, she's 6'12", N10. So eye with pathology, she's still got some peripheral edema, but she's very happy, and we've now done her second eye, and she's had a similar outcome on that side. Last case is a patient with quite a significant corneal scar from old herpes simplex keratitis. It's giving him this pseudo-keratoconic appearance with thinning and a steep island inferiorly, and that's his left eye. So you can see the left vision is quite a lot worse related to his cornea. So he had bilateral Vividi lenses as well, a toric on the left, so the DFT 415 means that it's a toric. He's done well on that side. The left eye he's done pretty well as well, but you can see that the reading vision isn't quite as good in an eye with pathology, and that's a common theme that I'm seeing. So is this lens utopia? Well, no patients have reported any lasting dysphotopsia or halos as yet. It does appear to be safe to implant in eyes with coexisting ocular pathology. Now, there's a big asterisk there because there's obviously many pathologies that I haven't encountered as yet, and these may be exceptions. So I think we need more numbers before we can genuinely say that that is the case. It gives good functional vision for modern times, and it's probably the lens that I'd have in my eye now because that's where my world is. And I haven't had to do a lens exchange to date. What about on the downside? Well, it doesn't give enough near vision for everyone. So if someone says, I really don't want to read without glasses, then they need monovision or a multifocal. The initial A constant wasn't perfect, but we've adjusted and now our results are much more accurate. Full range of powers is not yet available, so the company has not yet released a T2, so that's a low toric lens, and a very high proportion of our patients actually need a T2, and there's not a full range of dioptric powers, but I'm told that that's going to change next year, so that'll be good. We do have one patient who is complaining of visual quality issues. She's got some residual refractive error, but she won't let us take the lens out. She won't let me laser her cornea, so she must be doing okay. And some patients just take longer to get to that endpoint. And again, I haven't worked out exactly what the magic formula is, but some patients just take longer to adapt to the new lens. So what's next? The new range, and we are actually part of the Vivity registry, which is it's an international study with 50 sites worldwide. We're one of them. So if you've got any patients who would like to be included, that's looking at the outcomes from the lens. We're pretty excited to get that up and running in the next couple of months.